Because I got a bunch.
Posturing.
What's that?
Posturing.
Posturing, okay. So we got VA ratio. We got posturing.
Muscle
Okay.
testing.
Muscle testing.
Okay.
Okay. And what's kind of the overall theme of what we're looking at when we're testing for the PMRF? Did anybody pick up on that yet? Because almost everything I'm going to talk about falls in this category.
Autonomic balance.
Yeah, autonomic balance. Just think of anything that the autonomic system's controlling and test it. Okay? So we did increase VA ratio. So you want to look at sweating. So this weekend, you would take a look at the hands and the feet, and all you're looking for the color of it, right? Because you're looking for perfusion, and then you're also looking, is one hand sweating more than the other? Like for some reason this one is, probably because of the marker, right? But you're looking for, are the hands or the feet sweating more on one side than versus the other? And kind of along with that, you can also say skin temperature. So just look at the skin temp. And we're looking for pupil size. You love pupil size, right? You can also look at, so you can also take a look at the heart. So it's either going to be arrhythmia or tachycardia. Why would it be one versus the other? Say like one side of the PMRF is firing higher than the other. Which one would be arrhythmia and which one would be tachycardia? You guys know?
The right side be tachycardia. The SA node.
Wait, what? Sorry, I totally got lost in my notes.
PMRF is ranked up on the right side, you would expect tachycardia.
Yes, yeah, that's correct. So if you're getting left PMR decreased on the left side, you're going to start getting tachycardia, whereas if it's decreased on the right, you're going to get the stimulation. That's just because of the SA versus the AV. Thank you. Yes, Russ?
Are we for sure going to see tachycardia? Like, are you thinking like over 120 beats a minute, or
Good question.
severe arrhythmias? Are we just going to see slight increases?
Yes. So it's going to be, you're going to look for slight increases. With the autonomic system firing higher or lower, it's not going to be like this massive amount, like they're, it's going to be subclinical.
What are the normal ranges for heart rate?
So 120 over 80 is the classic, right? For heart rate, 60 beats a minute.
Okay.
It can be 40 is kind of like somebody exercises a lot would be okay. 60 is considered normal, and it can go up to 70 or 80, right? But we like to see it. I like to see it a little bit lower, so in the 50s. But it all depends on how much they exercise, stuff like that. So, anything else? That's pretty much all I had for autonomics. Does anybody else use anything that they test? Blood pressure. Good. So blood pressure.
2 meters.
Is everybody familiar with the pulse oximeters or O2 meters, stuff like that? And all it's really doing is you can get really cheap ones that are only like 20 bucks. You just put them on the end of your finger and it just measures the O2 perfusion. So not only are you getting blood and supply to your fingers, is it also perfusing out into the tissues? That's really what you want to know, because if you have all the blood in the world but you're not getting any oxygen to it, you're still going to have the same signs and symptoms of hypoxia, right? Or anoxia. Anything else? Paresis. So if you're looking in and you have them say ah, you would expect them to rise up the same. Now if one's drooping, why isn't it raising up as much, right? So take a look at palatal paresis. That's actually used a lot. So that's a really easy one to do too. Is if you're not really sure, take a look at the palate. So what we want to take away from this is one brain can fire higher than the other, right? And a lot of that activation goes down to the PMRF that has these different functions. And by evaluating the PMRF through these autonomic or peripheral signs, we're able to evaluate the patient pretty much objectively, right? Because if you are looking at the pupil size of the blood pressure, you can't say, I'm going to take your blood pressure, and then all of a sudden the patient goes, okay, it's down. You know, it's not something that they can control, so it's really easy to check every time. And that's why I love testing for this kind of stuff, is you can't fake it, right? So it's really good for you as the practitioner. And so that's the very basics of these two. And does anybody have any other questions about either of these two systems?
Treatment options.
Treatment options? Okay, great. So if you're looking just to treat the pons and medulla, you would want to do things that feed into the pons and medulla. We talked a lot about how the pons communicates with the cerebellum, so you could possibly do cerebellar activities. If you are thinking that you do the rest of your testing and you think maybe it's a cortical problem that's not firing enough into the PMRF, then you want to do treatments that are going to stimulate those certain lobes. So if it's, you know, you find out it's frontal lobe and it's still viable, you want to do frontal lobe stimulation. If you find out it's, you know, just kind of a global right-sided brain thing, you want to do maybe some, you know, active range of motion, stuff like that, to really get them moving. But like I said, this is just two parts of your evaluation. When you find out what's causing this to be problematic, then you can start your treatment options. So just like everybody else says in functional neurology, it depends. So that's the best answer I can give. All right, and that's it for today. And we're going to do, let's see, brain.